manage it. Yeah. Because this time is, according to you, is around 8:30 in the morning in US timing. Yeah.
Well, right now it's 5:26 a.m. in Seattle. So
Okay.
I'm on West Coast, remember, it's not East Coast time.
Okay.
So
Okay.
this is early morning and it's good timing for now.
Okay.
We can move things around. That's not a problem.
Because now the slowly, gradually, people are start doing a routine practice, and they keep on spending more time on clinics and examining the patient.
Yeah.
Just a couple of people, they approached me and they said, if next time onwards, if we can start it by 8 o'clock or 8:30 something. So it's a good time. We can finish up our OPDs and all. And we can also join the webinar. Yeah.
8:30 at night, India time?
Yeah, at night. Yes.
Oh, wow, that's late. And then they are okay with that? That's fine.
No, here see, this is a peak hour of their clinic. Because Sunday it's a holiday for the clinics. So like on Saturday evening, it's a rush for them. So that's why many people said that late evening, if you keep, then we also can join. So
that's fine. We can do that. That's not a problem. I mean, Saturdays are okay time.
So around for you, it will be like 7:30 or 8 o'clock in the morning, something like that.
That's fine.
Huh?
Ma'am, should we broadcast? It's almost 6 o'clock.
Yeah. Seema, can we start?
Yes. 1 minute. Yes.
Yeah.
It's live now.
Okay.
Live now.
But you start the webinar, right?
People are joining in.
Yeah. So I just shoot good evening message to all the delegates, no? Those who would be joining.
Yeah.
We are live on YouTube.
Yeah. Can we run the video till time, Seema?
Yes. वॉल्यूम नहीं आ रहा है.
Great.
You may often find them whimpering in pain every time they try to jump, run, or walk. Why does this happen? This condition causes long-term degeneration of joints, including many tissues like cartilage, bones of the joint capsule, and synovial fluid. This results in stiffness, lameness, and pain. Pentors is being introduced as an easy solution and treatment to osteoarthritis for your dogs by Vetina. This module is classified under DMOAD, disease modifying osteoarthritis drug. It constitutes of an active ingredient called pentosane polysulfate sodium that is derived from a plant source called beechwood, most commonly used as an injectable drug to treat osteoarthritis in animals. The Pentors works by acting at multiple junctions in the interconnected pathway of pathological changes occurring in the articular cartilage, subchondral bone, joint synovial lining, and the synovial fluid in an osteoarthritic joint. Degeneration takes place when mechanical factors act on healthy cartilage and subchondral bone, causing the release of proteolytic enzymes that break down the healthy tissues as well as cause the synovium to get inflamed, which leads to an abnormal synoviocyte metabolism, decreased hyaluronan size, and reduced viscosity and lubrication of the joint, finally leading to the breakdown of the cartilage and damaging of the bone. The damaged bone further causes synovitis, thus repeating the same process again and again until the complete loss of bone or joint function. What Pentors does is that it acts at a number of points simultaneously, breaking the chain and creating favorable conditions for bone regeneration activities. It inhibits the proteolytic enzymes and decreases the loss of proteoglycans as well as inhibits destructive enzymes like interleukin 1, interleukin 6, and TNF-alpha. Due to exhibiting partial heparin-like qualities, it also breaks down blood clots to increase blood flow to the joint, which cures bone necrosis and sclerosis and also reduces inflammation and pain, and finally increases the hyaluronic acid concentration in synovial fluid, leading to increased viscosity and lubrication in the joints, thus initiating chondrocyte regeneration of the damaged cartilage and bone. This Pentors works on many types of conditions, including osteoarthritis and traumatic joint diseases, osteochondrosis dissecans, degenerative cartilaginous joint diseases, musculoskeletal disorders, and periarticular inflammation. Plus, it has been proven to have zero side effects due to its origin being plant-based, thus being a completely safe drug for the dog. Choose Pentors. Relieve pain, restore function, renew hope. For inquiry, call or write to us on 912067 445858, 91750 6562266. Email ID customerservice@vetina.com. Visit us at www.vetina.com.
Shall we wait for another 5 minutes?
Yeah, we can wait.
Huh?
Yes. Shall we start, Dr. Seema? Let the people will join it.
4 minutes more, then we'll
Yeah.
start.
Okay. Good evening to all of you. Sorry to keep you waiting. We are just waiting for the couple of more people to join it. Yeah. So just bear with us for next 2 to 3 minutes. Then after that, immediately we'll start the webinar. Yeah. Thank you so much for your understanding. Let's start, Seema. Let the other will join in. Okay.
Last time we started at around, we waited for around 15 minutes.
Okay.
So that people could join in. So 2 more minutes and then we'll start.
We are really sorry to all of you people to keep you waiting, but it's a lot of people are still in queue to join the webinar. The number is increasing. So just bear with next few minutes and we'll start the webinar. Yeah. Shima, two participants raised hand. They have a question. Till the time others will join, can you please ask them?
Dr. Davis has raised his hand. Sir, please put your question in the question and answer box. We'll definitely answer. We'll be starting in another 2-3 minutes. I would request you to please put your question in the answer box. Yes, sir, there will be recording of this webinar on the YouTube and it will be shared. So you can watch this later on also if you want. It will be available on the YouTube.
Let's start, Simba.
Yes, yes.
Good evening to all of you. Yeah. Thank you so much to be joining me to be part of this webinar. As you are all aware of it, we started this series, a first webinar with Dr. Shanti Jai just a month back and got the overwhelming response of this webinar. Then we decided to continue such webinar to make you aware about more orthopedic condition and more the surgical condition. Right. So simply in the same series, Vetna brings you a knowledge-filled webinar on the topic of basic of orthopedic surgery. And that's would be the complete demand of orthopedic treatment, as we also bring you the complete solution for the orthopedic disorders. And certainly it is very well explained by Dr. Jha in a first webinar. And we decided to continue this webinar with the help of Dr. Jha. And again, we are here for you people. So I request to Dr. Seema to please introduce Dr. Jha. Let's start the session. Yeah.
Good evening to one and all, and I welcome to the second webinar of the series of the basics of orthopedic surgery. I would like to introduce our speaker for today. It is Dr. Shanti Jha, a surgeon, earned a Bachelor of Veterinary Science with honors from Nagpur Veterinary College, Maharashtra, India in 2001. After BVSC, he did an MS from Oregon State University in 2005. Dr. Jha was a general small animal physician for 1.5 years in Syracuse, New York, after completing an ECFVG certification from Tufts Cummings School of Veterinary Medicine. He then completed a surgical internship at Veterinary Specialist of Northern Colorado, Loveland in 2009. Following this, he completed a small animal surgery residency at Tufts Cummings School of Veterinary Medicine in July 2012. In 2013, Dr. Jha became a diplomat of the American College of Veterinary Surgeons, that is board certified animal surgeon. Before coming to AMSC, Dr. Jha spent time working as a chief of surgery at VCA Veterinary Specialist of Seattle for 4 years from 2012 to 2016, building an efficient team which helped him in helping small animal needing surgical services. Apart from general orthopedic and soft tissue surgeries, Dr. Jha has also been heavily trained in minimally invasive surgery techniques. He has been doing minimally invasive fractures repairs and arthroscopic correction of joint abnormalities for the last 4 years. He thoroughly enjoys laparoscopic and thoracoscopic procedures like lap-assisted gastroplexy, laparoscopic ovariotomy, laparoscopic biopsies, thoracoscopic pericardiectomy, and thoracoscopic partial lung lobectomy. Dr. Jha is also an AOVET faculty and enjoys teaching orthopedic courses in US and abroad. His orthopedic areas of expertise include arthroscopy, fracture management of limb and spine, angular limb deformity correction, and joint surgeries. His other orthopedic interests include joint replacement surgeries like total hip arthroplasty in dogs. We welcome Dr. Jha. Dr. Jha?
Yeah, Seema, thank you very much for this introduction. I'm just going to share my screen and start the webinar.
Yes.
All right. Well, good evening, everybody. So last month or so, we talked about basics of orthopedic surgery, and we decided to discuss radius and ulnar fracture repair basic techniques. Today, we're going to move on to one of the easiest bone to repair, which is tibia fracture. And again, it's a basic surgery techniques, and we'll go over a few of things. And as Dr. Tadokar said, that I'm interested in minimally invasive surgery. So there is a case for a minimally invasive surgery also. So you will hopefully enjoy it. So let's get going on that. Well, many of you, I'm on Instagram and I continue to post these cases. And if you guys want to follow me, you can. I'm on LinkedIn. I get messages from a lot of veterinarians from home, which is always good. So continue to do that. So, Jason, क्या कर रहा है? Setup कर रहा हूँ chapter fracture. अच्छा, setup कर रहा है. कर बेटा. I always play a video. So that's my assistant, Jason. He's setting up for a tib fib fractures. That's what he's telling us. So let's go ahead and look at some tib fib fractures. So what are our learning objectives here for this lecture right here? So after the lecture, you should be able to describe the fracture configurations of tibia based on orthogonal radiographs. So once you see 2 radiographs, you should know what's going on, what is a fracture. That will help you repair it. And then you need to identify appropriate methods of fixation for various tibia fracture configurations. We'll go over a few which are the most common tibia fracture configurations. Most of the times I'll be asking you questions, is it repairable, yes or no, and what things you will be using. Feel free to write down in the chat window so that Dr. Taravar can continue to read that, and we will have some kind of response in that. It's always good to have you engaged and have some discussions as we go. And then we should be able to know what are the advantages and disadvantages of fixation methods for tibia fractures. Just knowing an appropriate method is not good. You need to know, can you do it properly, and are there more advantageous fractures repair techniques that you can use? So hence, I always do planning, and it's been almost since 2009, I've been heavily trained in surgery. It's been 10 years, 11 years, I still will plan for every single surgery, and I will calculate how many screws I'm putting and what's the length of the screws, what's the direction of the screws, what kind of plate I'm putting. I'll measure everything. You'll see some examples there. So it's very, very important that you properly plan each surgical procedure so that you have a proper imaging approach, stabilization method. And if you don't do these things, what are the things going to happen to you, to your patient, to the pet parents? There will be increased surgical or anesthesia time. Not good. Every 30-minute increase in anesthesia time increases 5% chances of infection. You don't want that. Not every infection can be treated with antibiotic. The proper treatment for an infection, which will happen in future, is to do a proper planning. It's very boring to do a proper planning, but it's a prophylactic step. That's why it's pretty boring. Okay, so if you don't do proper planning, you will have a good amount of soft tissue trauma. You will not know how to approach properly, and then severing vessels and nerves for no needs. And there will be increase in technical errors, which all increases to complication rates. In every fracture surgery repair webinar, I start with these things that as surgeons or budding surgeons or enthusiastic veterinarians who are trying to help a broken puppy or a dog, let's plan properly. This is just an example to show you that, okay, I'm going to repair a tibia. Of course, it's an advanced surgery. You can see that in my monitor right there, that I have a CT scan of a angled tibia. So it's an angular limb deformity, but I'm planning it properly. And then I will relay this plan to the team member, which could be in India, it could be 1 or 2 persons or just one person, that, okay, I'm going to do this, this, this. Are you ready for these things? Yes, I do relay these plans even to the technicians or the nurses. Okay, so that was just a quick intro for all those things. So let's deep dive into cases, and we'll be 4 or 5 cases here to discuss. So this is a 2-year-old castrated male lab presented with right hind limb lameness as he was trying to jump on the back of a truck and then landed on the ground and then fractures his right tibia. So that's his x-rays right here. So let's talk about the bone tibia. Tibia doesn't have a lot of muscle barring the gastrocnemius and then cranial tibialis, okay, the calf muscle. It will rupture, it will break even with small amount of injury. As you jump and turn or twist, there is enough of torque that will cause the problem. So although since the impact is low, there's most of the times the fracture is also just simple fractures in tibia. And hence I say that the tibia fracture is one of the simplest ones to repair, although you need to follow the principles. So here is the tibia right here, as you can see. So what I would like you guys to do, even in chat window, in describing these fractures, you should be able to know, like, for example, here I'm seeing that this is a closed It's a complete fracture, and it's an oblique. You can say that it's a spiral also. Where is this fracture? It's mid-diaphyseal. And then you look for, is it displaced or not? So it's cranioproximally displaced. Then the type 4-1A, you don't have to worry about that. That's an AO classification for humans. 4 is tibia, so 1 is humerus, 2 is radius, 3 is femur, 4 is tibia. Don't worry about those things. So the first few lines are important. Let's go over this again, because you'll be doing this for the next fracture. It's a closed fracture. You don't see any pockets of air. The bone is not poking out of the skin. Is it complete? Of course, it's a complete fracture. Then what's the shape of the fracture? It's an oblique and spiral. Where is it located? It's mid-diaphyseal. And then the displacement. Whenever we see the displacement, it has to be the lower fragment, the distal fragment, okay? One very, very important thing to notice is that F for fracture and F for fissure. So if you clearly look right here, see right at the cursor, I'm moving this bright spot, and you can see a fissure line going down here. So the fracture starts here and then it wraps around and then comes down. If you do not identify those things, it's a problem. Spend a few minutes looking at the fracture, making sure you can define it, making sure it's where it's located. In future, if you have a question, you want to shoot that to me, I would expect that you should know how to classify a fracture, how to describe a fracture. So that will make your and my life very easy, and I can make some suggestions. Okay, in the chat window, I would say, feel free to answer yes or no for the case one, yes or no, something like that. So my question to all the attendees here is that, is this fracture reconstructible? So yes or no, and then would you choose, excuse me, anatomical reconstruction, yes or no? I'll give you like a minute or like a few seconds to just answer that in chat window. Okay. So let's decide that you decided that, let's say that you decided that it is a reconstructible fracture and you will use an anatomical reconstruction method since it's a simple fracture. So if it's simple, reconstruct it, that's not a problem. First question, again, can you reconstruct or not? What fixation methods you'll be choosing to use to repair this? So let's go over those. So compression plate, do you want to use a neutralization plate or the advanced technique for interlocking nail, or you use a bridging plate, or you use a plate rod construct, or you use wire and iron rod? So these are definitely a lot of options here. I mean, you can also say that, well, Dr. Jha, can't we use casting? Of course, you can use cast, but are we using the standard of care, or are we trying to raise to the gold standard of care? I mean, let's move out from 1970s to 2020 and use proper methods which are available if you can. I'm not saying that you can't. And then the other thing would be the X-Fix is a completely normal method to be used here. This is a very simple fracture, and I'll be honest with you, I'm not an X-Fix guy. I do ORIF, which is open reduction internal fixation. And when I say open reduction, that could be small also, that could be big also. So here's the repair. This is what I did in the early days. Very, very simple repair. So I put a rod, aligned it, looks pretty good, neat and clean, and I put some wires there. And I made sure that I have wire down here so that it's getting to that fissure line right there. And of course, you can see this big rod going through there. So let's talk about this. Anytime you repair the fracture, you should sit down and critique your own fracture repair. Like, what are the mistakes you have done? Okay. So tibia is an amazing bone where it's kind of a small triangle distally, and then again a pyramidal or triangle shape proximally, but in the midsection it's a perfect cylinder. So wiring a midsection is completely fine, and yes, you can go around the fibula if there's no space around, because you can see that fibula is just kissing this tibia right here very tightly, and there's no space. So that's how the wiring is done. Everything went well. The dog was happy, goes home. So how do I assess my fracture repair? We can go through a different lecture, which is radiographic assessment of fracture repair. It's like one of the topics, but what you have to decide is pin position. Is pin position perfect or good? Yes, I would have placed this a little bit more longer pin distally. Is pin size okay? It should be about 60% at the isthmus, which is the neck of the bone, meaning that the smallest portion of the bone in the marrow cavity. So as you can see right here, it's covering almost like 60%, 50 to 60% of that pin and the diameter. And then you decide the cerclage, type of cerclages you'll be putting. We'll go over those. How many are you going to put? Where are you going to put? So the position. And is a fracture reduced properly? Well, I can't see fracture lines here, so it's a bit very well reduced and looks pretty good. I was happy about this, and we're like, okay, dog is all set, can go home. Let's go over some principles of wiring here, and they're important. So first of all, anatomical reduction must be all around, so 360 degrees. If you're not able to reduce the bone fragments, do not put wire. There's no reason to put wire. It will not hold. Go and take up a different method. And the proper fracture configuration to put wires to reduce the fracture. Look, I'm saying reducing, I'm not saying stabilizing. Okay, to reduce the fracture is at least 2 times the diameter of the bone. So the obliquity of the fracture was at least two times the diameter of the bone, and this was the perfect case for me. And then the wire should be at least 1 centimeter or 1 bone diameter apart, not 1 centimeter, because in a bigger dog it could be 2 centimeters. In a smaller dog it could be 4 millimeters. And then you must place the wire perpendicular to the long axis, so 90 degrees to the long axis of the bone. Of course, wire should be placed tightly, no question about it. And then the last point right here, which is must be used with additional fixation. If you are planning to repair a fracture with just wire, please don't repair it. It will fail. There's no question about it. Wiring is just to reduce the fracture, and then you need to augment your repair with something else. So in this case, I put a rod in. So the bony column is constructed, rod is there, and hence everything was all set. So there's 3 ways of wiring techniques. So simple is a twist, or there is a single loop and then double loop. Looking at my x-rays, and you'll see again, it was just a twist, a normal twist. Now looking at the twist, let's look at these numbers right here on your right side. So it takes only 260 Newton to disrupt that twist, or even the single loop. So not a strong repair, but do you need a strong repair if you're putting a rod in? Probably not. That's what I thought, and I just put that rod in. Double loop is the best one, and I'll use that invariably if we are doing a total hip and I have accidentally fractured the femur. I'll use a double loop because I want that to be properly placed, and it is the strongest wiring technique. For that, you need a wire twister and a wire passer and a wire tensioner. So you definitely need a special instrument for that. Okay, this is 1 week post-op. Let me blow this up a little bit. So what you're seeing right here is, this is the fracture, the day of fracture, and then I repaired it right here. And now this is 1 week post-op. There is definitely something funny going on right where between the second and third wire. So my fracture repair failed. And why did it fail? The question I was asking to myself was that, is wiring technique good in this guy? Well, yes and no. The reason for that is this dog was huge, and he would be putting a lot of weight on this tibia, the repaired tibia, and I should have used some other technique, because you need to look at the patient, you need to look at the technique, and then come to a conclusion what we should be using. So again, looks pretty good, repair, and then boom, 1 week post-op, it's completely disrupted, and you can see that the third wire, which was not placed perpendicular, has failed. So it was moving. It is important to note that wiring can be a little challenging. It looks very simpler, but it could be challenging. So what we have learned in this case is that wiring, iron rod and wiring is perfectly good technique, not for every single patient, unless you're placing it properly and there is an augmented repair. Now, I did not put him in a cast or a bandage. I normally don't for these techniques if everything is healed or everything is going to be healing. And the patient was walking a little too much, which could cause this. But I think that surgical technique, what I used, wasn't that great. So another shot right here, as you can see in left, looks pretty good. And the right, it's just failed on us or on me. I could have used a different wiring technique, like a double loop, which could have been better. And I chose not to do it, just wanted to use a simple method. I like to keep things simpler, but at times things can fail. So be careful about wiring technique, how you're using it. I still use wires, and I'll use this to, if given a chance, how I would repair this. Okay, I can use a wire, I can put a lag screw to reduce the fragment, and then I'll probably slap a plate on tibia. That's basically it. Plating is my favorite technique for many bone fractures. So that's the end of the case 1. We'll look at case 2 and continue to have a discussion right here. So I'm going to stop here when we were asking about you to describe the fracture so that you can spend some time looking at the bone. It's a 1-year-old lab, again, running around. I am playing with the housemate, fractures his tibia. So he was presented to me. What is this, Oliver? Oliver presented to us, limping, of course. Come back. So he was playing with his housemate and broke his leg. So tomorrow we'll fix his broken tibia. He's so happy to be here. Okay. So again, normal running around here, and you can see the left side is completely in bandage, and there is a splint sticking out. And a pet parent, I think, drove like 2-3 hours from south and wanted me to fix right then and take him home. And I never saw him back, but I saw a video of him running around after repair. So let's look at this. So here's the fracture. What I want you guys to do is look at this, and then if you guys want to, like, quickly in chat, just post some comments for case 2. What kind of fracture is this? We'll wait for a few seconds.
Yes.
Please mention case 2 and then write your findings. Okay, so let's look at this again. So here is another view right here. So is it closed? Of course it is closed. You can't see any air pockets. So normally if you see air pockets, will be around this area right here or there. So as bone is poking out of the skin. So I don't see any air pocket. It looks pretty good, solid. And then it's oblique. I see that oblique, and it is spiral. Look at this again. See this fissure lines. Always be cognizant of that the fracture, when it happens, especially in tibia, even in femur, you should look for fissure line. Okay, so is it a compound? It's an oblique shape. You can see spiral oblique. Is it compound? Yes. The reason I say compound, the fibula is broken and there is a small broken piece right here. It's a free floating piece right in the dead center. It's severely displaced mid-diaphyseal. You don't have to worry about type 4-3A or so. Okay. So in the chat, just say case 2, yes or no for your reconstructible or anatomical reconstructible or not. So first question is that, is this fracture reconstructible? So you need to look at this properly, and then only you will be able to decide that, okay, I can reconstruct or not. If you decide to reconstruct, then you should know, or you should start discussing with you your team, is that what methods you'll be using. Well, this video you saw, so this is actual video for this dog. So I'm asking him again. Okay. They don't talk to me in Hindi. This was just a setup. I just wanted to introduce this to you, and he's very interested in learning Hindi. So I sometimes talk to them in Hindi. Okay, so
so this is a hanging limb prep. So the limb has been hanged right there, and I do 3 drapes, and we'll put a clamp.
okay, so limb is hung, and I'm just gonna clamp the towels around so that we continue to prep this. Some of you followed me on Instagram, but this is what is very, very important before every fracture, before every surgery. So running a checklist. If you haven't read Checklist Manifesto by Atul Gawande, I recommend that you should read it. So this is a checklist.
Okay, I'm ready.
Antibiotics been given.
So you're running the pre-incision checklist? Yep. Okay, yes.
Antibiotics been given. Procedure site grade.
So left tibia fracture, so about 40 minutes.
Pulse oxygen working.
Okay, good.
Central images displayed.
Okay. Essential images, yep, being displayed. Okay, good. Next.
Routine steps.
No routine.
Specific concerns.
I don't have any concerns about the patients. Do you? Okay.
Sterility confirmed.
Yes, they have.
Equipment issue.
Nope, working good. Okay, you're ready to go.
Okay, so I've run the checklist and now I'm ready for fracture repair.
Okay, well, difficult fracture to use, but we found a way to align it properly. And now what we'll do is we'll put this rod into the tibia with alignment and then make it smooth. All right, you can stop.
Okay, what I just said was this was a difficult fracture to repair or align because there was a small fragment there. It's so important that if a complete disruption of bony column has happened, you need to align it properly. Otherwise, the foot is going to be like this and the dog is going to walk funny, and then pet parent will not be very happy with you. So I'm paying some attention, making sure that we are aligning it properly. The best method for aligning is to put an IM rod. So that's what I'll do. So I'm ready for the IM rod. You can't hear properly what I'm doing just because the suction unit is going on. It's a little too loud, but let's see this.
Yes? Okay, so we placed the rod, which is about like this big, and now what we'll do is we need to adjust it with this chuck right here.
So I'm adjusting the rod with the chuck, making sure that it goes to the proper length.
And we keep pushing. Stop. That's good.
Okay, so rod has been placed. I'm super happy with that. So now, again, the rod was just to align it. It's not a normal fixation method. So now I'm gonna put a plate. It will be a neutralization plate, or you can still say bridging plate or so. And what are the different kinds of plate and how you can use it? Again, fracture biomechanics, completely different lecture.
Okay. All right, we've chosen this plate right here, which is a gentle S curve. We'll go on the tibia. Okay, we'll do that.
Okay, tibia in general has a gentle S curve, like super gentle S curve. If you don't have to contour it, just put an S curve for the full length, and then you can just put that on the tibia. And that's the technique I use for when I'm doing MIPO, which is minimally invasive plate osteosynthesis. Okay, so surgery is done. Now our team is gonna take some x-rays.
All right, so we are done with the surgery, and we're just shooting x-rays.
Okay, no.
And it looks good. Fantastic. Nope, we're good. Well, can we crop it? Actually, I don't want it. That's right. Yes, thank you guys. A bandage coming shortly.
Okay, so here's the repair. So again, looking at the repair, you need to understand that what method did we use? Is it repaired well? So we read like 4 A's or 3 A's, which is it anatomically aligned properly? So looking at the joint up or down looks pretty good, solid. Is A for apparatus, another A. What apparatus did I use? Oh, well, I use a plate and a rod configuration, looks pretty good. And then how is this opposed? And looking at the fracture repair, looks pretty good. But let's look at this fragment sitting right here as I highlight that. So I didn't bother to bring that fragment close to the fracture gap. Being an orthopedic surgeon, gone the days when we were carpenters. Orthopedic surgeons should be gardeners. You need to handle the tissue very, very softly and gently. That dog healed well. Again, whatever the name of that dog was, the only thing I saw was the video from the cell phone, and the pet parent never came back. The RDVM, which is the referring general physician, called me and told me the dog has healed well. Okay, this is case number 3. So he's an 8-month-old German Shepherd playing flying disc or frisbee with the owner. A dog was running around crazy. Of course, you know, they fill our lives with so much of joy doing funny things, but he lands abnormally, and then the pet parent hears a crack. Well, when you hear a crack, when the dog has landed, that's a big problem. Well, here's the problem: fracture. Give yourself some time. Again, Dr. Tarago, let's wait for a few seconds. Let the participants describe this fracture. Remember, it's a young
even
dog.
I would suggest that, because in the last 2 cases, there were people who were responding, and we should give them some time.
All right, let me know. Let's use like a minute or so that people can look at it. Look at this fracture and let me know what you think.
Is an answer compound oblique?
No, so let's go ahead and look at this. So this is a closed, of course, and you can argue that this could be a green stick. Remember, it's an 8-month-old dog, 6 to 8-month-old dogs. They don't get complete fracture all the time, but it is a complete fracture that is going through both cortices. The reason I know is because it's a spiral fracture. So it starts right here, and then it wraps around the tibia and then goes back right here. You can see there is a fissure line or fracture line right there. So it's a closed fracture. It's a complete fracture. It's a simple fracture. It's not a compound fracture. Fibula is intact. That there's not a lot of displacement. It's actually no displacement here, and it's a 4-1A fracture. I mean, I would love something like this coming to our clinic or our hospital. Or if you're a budding surgeon, you're trying to learn the art and science of surgery, pray that you get a tibia fracture and simple. Start simple so that you can learn. This is a very simple fracture. So question here again, is this fracture reconstructible? Let's just type your comment like case 3, yes or no. And then would you use anatomical reconstruction, yes or no, or so?
There were 2 more answers, like closed fracture oblique, and then another was hairline green stick fracture. Now,
Yeah,
yes.
I will take both of those as correct answers.
Yes.
But the green stick is a very, very valid answer, although it wrapped around the bone and I could see that it was fractured on the other side. But they do get green stick fracture. Okay, so you've decided that this is the fracture and you know that how it's a simpler kind of fracture. What do you do? Like A to F, there's enough of a repair method here. I did not, again, put cast. I'm not a cast person for fracture repair, but after repair, I can put some bandage for a week or so and not before the fractures, or that's not the primary method of putting or repairing a fracture in my world, basically. There are some cases that you can use it. It's a puppy and I didn't want to put a cast. It's going to cause contracture of the muscles and tendon, and it's just a messy business with pressure sores and other stuff. So I don't do casting.
There is an answer: plate and rod construction.
Okay. Yeah.
Anatomical can be repaired.
Okay, good. So yes, it's an anatomical reconstruction. You can repair this with a little bit of displacement. It's already like anatomically reduced and aligned. So that's good news. Good answer. Plate and rod is a little too heavy for this dog. The reason I say that is that it's not a compound fracture. When there's a compound fracture, alignment issue, then you put a rod. If there's none of those things, it's a simple fracture and you can construct the bony column, put a plate so that the bone and the plate, they both can bear weight and then dog can be happy. What I chose in this case was minimally invasive plate osteosynthesis. So as Seema mentioned before that, I'm interested in those and I do quite a few.
Here, Dr. Jha, one more thing. One of the doctors is saying simple pop and bandage with rest as dog is young. And another answer is putting a cast. So
yeah, as I mentioned before, that I'm not a big fan of those things. And I also gave you the reasons for that. Again, it's messy, can cause contracture, pressure source, and dog continuously going after the cast. I mean, it's could be a standard of care, but I don't do that. The reason is that if we have better techniques, why not use better techniques? So I chose minimally invasive plate osteosynthesis, which the reasons for that is it's a mildly displaced fracture, intact fibula. So fibula is already used as an internal splint there. This is not a candidate for pin and wire. Let's talk about the pin. Pin shouldn't be used in a growing dog because you're going to go through the growth plate and you'll destroy the growth plate. So I don't use the pin in a growing dog. And then I'm going to use a biological fixation, non-anatomic, meaning that I will not touch the fracture site. We'll just leave it as is. And I wanted to try a different method. And since it's a young patient, that can be done. Did my calculations and planning and measurements. So here's something what I'm doing. So you can see that this is the morning right after cup of coffee. I'm planning this, and this is the actual plate is going to go into the bone later in the day on the dog. So I'm planning on the x-ray right here. So I contoured the plate and it's gone to the central autoclaving facility where it will be autoclaved, sterilized. So I made 2 incisions, putting my bone in holding forceps, as you can see right there. And then my index finger right there, right here is holding the paw. And I'm making sure that this whole leg is aligned properly. Well, alignment is important. Once I was happy with the alignment, I'm gonna put a small iron pin going through the fracture. See this right here? That's just going to, and then this right here, that's just going to keep it reduced for the time being. And then I created a epiperiosteal tunnel underneath the skin and tendon of the tibia or the bone right there, you can see. And there's a free air going back and forth through this tunnel so that I can slide my plate. Here's a plate outside, and then boom, it's inside, as you can see. Of course, I'm using advanced techniques and I'm using C-arm. It is costly, no question about it. But at some point of time, I don't look at the cost. What I'm looking at that, can I repair this dog's broken bone and give him or her a better quality of life right away? And then if the cost is not that bad, we'll just use this technique. And this technique was totally suitable for this young dog so that we can use like extra $1,000 to use the C-arm and a different technique. So this is during the surgery. You can see that I put my plate, few screws up, few down, that's about it. I have not touched the fracture in the center. And again, looking at this right here, it's still like mildly displaced. There's no need to touch it because you can see that it's aligned well. And that's what the comment was, that you can put a bandage and cast and it will heal. Of course, but there's a lot of complication which can happen. And you're here to learn like basic advanced techniques. So that's that. I was happy with that. Put some sutures. This is day 1 post-op.
Okay. Slow, slow.
I was getting nervous. It was like trying to run. Okay, so as you can see that dog was happy, and this is only 6 weeks post. The fracture is completely healed. You can't see anything, and there's of course the plate and screws are intact. Yes, I did use a locking plate system, and most of the times I use locking plate system or a hybrid plate so that I can use it as non-locking and locking totally fine. Quick tips. Pre-planning, very important. And then if it's a simple fracture, you can just little compress it little and then put your screws and plate on top of that. Now, if you want to do this, I'll recommend that you can make a really small incision just to see the fracture during the surgery. If you don't want to use C-arm or continuous x-rays there. Now, sequence of screw placement is super important. I combine non-locking and locking screws. So first, you have to put a non-locking screw so that the plate is lagged onto the bone, and then you can put the locking screws to stabilize it. And then you have to use the basic principles of locking, compression, plate application. Advanced technique here, if you have to attend this, you want to continue to do that, you can use one of the AOVET courses I teach here in US. By the way, we will be probably talking about having an AOVET course in India. The first one was in 2012 in Chennai and was hugely successful. So we are in talks so that we can have an AOVET course back in India. So again, that's that. Now, of course, they paid a few extra couple $1,000, and luckily that dog was insured. And I'm like very impressed by this initiative from Vetina, is that they have something like that where the pets are insured. And I was just, again, going through them. I've mentioned this before. I'm thoroughly impressed. They're on top of this and on par with any other insurance provider in this world. Some of them are like, some of the plans there are like much better. Encourage your pet parents to get your dogs and your patients, cats and dogs, insured so that you can properly practice medicine. For us veterinarians and given human surgeons, they can do anything they want. We can't just because of the finances. It's important that most of our pets are insured, and we will have a better way of repairing them. And then we won't be even talking about using an inferior method. It will be all a better method. I feel lucky that I'm able to use these in many of our pet parents because most of the dogs here are insured. Okay, going back to our cases. This is case 4, little interesting. So we've learned a lot here. Let's look at this case and see what else we could have done here. It's super important not to take fracture repair so lightly. Okay, I'll wait for the answer right here. Just type case number 4 and then 1, 2, 3, or 4. That should be your answer. So is this fracture reconstructible? The dog is running around and then broken bone right here, as you can see. What I would like to see is it reconstructible? So basically, yes, maybe. Number 3 is no. Number 4, it doesn't matter. Seema, let me know when there are a few more entries, and then we'll move.
Yes. Most of the people have said yes. Closed midshaft compound fracture. Most of the people have said yes.
Okay. Okay, so that's good. Let's talk about this. So it's a reconstructible fracture. I'm glad that I'm lecturing here, and it's just amazing to have a discussion and have a lively audience like you. So my answer was no, it is not reconstructible, and we will know why. Okay, I did not do the first surgery, but here's the method how I roll with this. Here's a fracture, good. I'm gonna look at the orthogonal radiographs, so 2 straight radiographs, and then I'm gonna see, is it biological or is it mechanical, meaning that anatomical or so. And then I'm gonna think about like, what is the healing time? This is a mid-aged dog, and then I give a score to the dog, looking at the dog, the fracture. I was like, okay, yeah, it will heal. So anatomical reconstruction, Many of you said yes. I'm gonna take that yes and we'll roll with that. Okay, well, if you said yes, what are the methods you'll be using? Well, it's a compound fracture, so we decided that can we use an open reduction and rigid internal fixation, which is an important one. So I call that as ORIF, which is open reduction internal fixation, ORIF. So, and then what kind of plate are you going to put? Neutralization, compression? Well, it could be a bridging plate or so. Okay. Well, here's the repair. The medial lateral view is kind of a little blurry. I'm not sure why, but look at the CC view or craniocaudal or BD view, this view right here, okay? Again, right after the repair, you need to look at this and do the 4 A's or the 3 A's. What is the apposition of the fracture? It is opposed properly. A flat out answer is no. The reason is that this bone is sticking out right here. This is a nice wedge which is not into the fracture bony column or into the repaired column. So answer is no. That's a problem, okay, because the methods used here. And then alignment. Is alignment good? So alignment is a joint up and then joint down. So let's look at the proximal joint. Looks pretty good, solid, going back normally right here distally. So alignment is beautiful. The bone is straight. Super happy about it. Then we look for other A, which is apparatus. What did I use, or what did the surgeon use? I didn't do the surgery. Used an LCP, a locking compression plate, and then some non-locking screw, and then some locking screw. Locking screws have more pitch. Non-locking has less pitch. Then the last one is activity, which is the activity of the bone, not of the dog. And you can't judge the activity because bone hasn't started to heal. Okay, so looks solid. I mean, many of us think that this was a reconstructible fracture. In my mind, as a board certified surgeon, I was like, no, it's not. Okay. Well, this is 2 weeks after. So I decided to take an x-ray. This is the x-ray 2 weeks after. So again, I'm glad that we're having these discussions and looking at a complication. Always remember that surgery will make you humble. You can do many surgeries, but there will be a case which you'll have to go back to your drawing board, sit down. That's why I keep saying plan properly. Look at the case and then go from there. It's not like, okay, TBI is a simple fracture, simple bone to repair. You still have to follow the AO principles. Okay. So the fracture has failed, and of course it failed because it was not done properly. So anatomical reconstruction, going back to the flow chart, and we need to move that yes away, and then whosoever answered no is correct. It was not an anatomical reconstruction fracture repair here. So now what you would use? Well, I think we need to bridge the fracture with a bridging plate, and then I will still use open but do not touch technique, and then repair it. Well, before I show you what I did, let's discuss about fracture patient assessment score. I would like all of us surgeons, when we see a fracture, sit down and think about the dog and the bone and yourself and then the pet pair. There's so many factors before you pick a method to repair it. So what is the patient going to do after you have repaired the fracture? If the dog is going to run around like this, you better choose a proper method so that it's sturdy and it's not going to break. And then again, look at the type of fracture. What is the type of fracture you're going to repair? And then what methods are you using it? And then the last one is experience of the surgeon with what you have at your disposal. Looking at all these 4 factors, give that fracture repair or the fracture a score. It's out of 10. You can do 500, I don't care. More the score, better the repair chance or the healing chance. So for a small dog, young dog, case number 3, where I used Beeple, I give it 9 out of 10. I never give 10 out of 10. 9 out of 10 is a young dog. I'm going to use this method. I know what I'm doing. Dog will heal in 4 to 6 weeks. Dog healed. This dog was a heavy set dog, compound fracture. Surgeon was inexperienced. He was one of my residents in Seattle who repaired this. So the experience definitely works, and the methods used. So he didn't use a proper method, I should say. So in that case, a fracture patient assessment score should be low. But in my mind now, I'm going to look at this. I'm going to say still it's repairable in my hand. I'm still going to give this fracture repair, which I will revise, is 9 out of 10. You will see why. Okay, what do you need for your planning properly? You need proper imaging, your planning guide, patient, of course. Approach is so important. Don't get into the habit of making tiny approaches when you start repairing fractures. Just flat open. Of course, use proper gentle technique. Look at your inventory. What do you have to play with? Do you have locking screw? Do you have locking plate? No locking plate? Do you have rod, wire, everything? And then who's helping you? I know there is less help there. Sometimes you just do on your own. I do that, so do that also here on my own. But at least the setup is important. So I relay my planning to my team. And then ask yourself all these questions. And how are you going to use it? Is it absolute or relative stability? What are the approach or approaches? And then are you using open but do not approach or minimally invasive? And then of all these, which one will cause minimal soft tissue damage? I'll repeat this again. There's no need to hack and slash your approaches. Please make sure that you have done a gentle handling of the soft tissue. Anybody can put a plate on a bone and put some screws. It will look great on the x-rays, but if you have cut the blood supply, severed the nerve, there's not a good outcome. And hence, it's important that you respect the soft tissue. We are gardeners, not carpenters. This is what I did. So I aligned it, removed the plate, and made it straight. And then I'm gonna drop a rod in, so that's the rod, and then I brought a plate in. So that's just an animation for you to see what I would be doing. And then of course I put some screws, and most of the times these were like locking screws. You can use non-locking, that's completely fine. So again, on this side, this was the fracture and the plan, and then the repair right here. Dog healed well, no problems. And again, I didn't touch the fracture in the dead center. There's no need to. It's already healing. Body is trying to heal. You just have to support the body for that. So complication, and then the revision. So in summary, for the whole tibia fracture repair, in general, the long bone repair is preoperative planning is super essential. Of course, we all have numerous options available, but tailor them then to your patient, to the pet parent. I mean, it's so important that you repair a dog, and then the pet parent is not with you, and he or she lets the dog run around. You have an ultra short success repair, but in 2 days that fracture is going to fail. So it's important that they understand after spending tens and thousands of rupees or so. And then again, make sure that it's all based on mechanics and biology. The best chance of a successful outcome is with an appropriately planned and executed first surgery. Take your time. Don't think that if it fails, oh, okay, I'll repair it later. No, make sure you properly do your planning and then go from there. All right, this is one of the papers that you can read for MIPO if people are interested in MIPO. It's written by one of my friend, Laurent. He is in California, and we both are AOVET faculty. So he started repairing these with MIPO techniques. I know that in India, people are doing it, which is good. So continue to do those things. But this is again in veterinary surgery and published in 2010. So that ends our discussion on tibia fracture, and hopefully we'll continue for humerus and femur in future. But what I'll do is I'll unshare my screen so that I can go back to Dr. Talker's screen, and then we can answer some questions. Seema, it's all to you. If there's any questions, we can answer.
Yeah, there is a question.
Yeah.
For case 4, could orthogonal plating be kept as an option for revision surgery?
Case number 4, orthogonal plating. Does that mean 2 plating? If you're asking for 2 plating, yes, we can use 2 plating, but not just 1 plating. This needs at least 2 plates if you're just going to use plate. So answer is yes, if they're saying orthogonal.
Yes.
By the way, the definition of orthogonal is straight. It's not just like 2. So we need like orthogonal is when you look at something, it should be straight. But yeah, 2 plates can be used.
Yeah, there's one another question from Dr. Anjali that as the fibula was not aligned during second surgery of this case for compound fracture, is there any chance of malalignment alignment of fibula, and will it cause harm?
Okay, very good question. So good observation there. So fibula is important only proximally and distally. Don't care about midsection. I really don't care about fibula in the midsection. It will not cause any malalignment. However, if the fibula is broken distally, you better repair it, and we can have a different lecture on that, or even proximally, because distally fibula is one of the bone of the joint of the ankle joint, and proximally it still takes a lot of load. So in midsection, there's no problems. Same with the ulna in radius ulna. It's a 2 bone system. So in the midsection ulna, don't worry about it. Distally and proximally, yes, you should be able to repair or align it. Okay.
Another question is what to do when patient is not compliant, like keeps running around even after repair. Kindly suggest.
They're dogs. They're meant to do that. God or nature made them to do that. I fail on that also. So here's what I do. I have nice man-to-man or heart-to-heart talk with the pet parents. We sit down, and you need to talk to them with a little bit of authority and not with overconfidence, but with confidence. This is what I tell them, that look, Mr. or Mrs. Smith, well, I call them with their first name. So let's say, Kayla, we'll be repairing, Oliver's fracture, but I can repair it, but the fracture repair success depends on you, how you handle Oliver at home. Because again, ultra short repair success is great. For 2 days, dog is fine, but 3rd day, dog is running around, it will break its leg. So this is what I send them home with. I use drugs, trazodone. You can use codeine, some kind of narcotic, or you can use acepromazine just to kind of like calm them down. Sometimes I'll bandage or put a splint if the dog is really crazy. There's no easy answer for this, but very good question. You need to make sure that the pet parents are also involved in these decision making, and they understand that if they're not paying attention, this will be a problem. I don't want to scare them that, okay, if you will come back for revision, it's much more pain and things will be a little messy. But honestly, I tell them that yes, it's a dog, but you need to be properly handling it. The other thing is that if you're using a proper method of repair, and if bony column is repaired well, and your apparatus is all set, dogs will do fine. Not that running around will not cause problems. A little bit of accidents here and there should be fine. However, you take help of some drugs. That's a short answer.
Okay. So another question is, what about external fixator in case number 4? Is external fixator can be used in this case?
Yeah, well, very good question, Dr. Pawan Kumar. Yeah, very good question. Yes, you can. And actually, tibia is one of the friendliest bone to use X-Fix. And I've used X-Fixes on that. I normally don't use X-Fix. It's not that you can't use it. That should be a completely fine one to repair. You can use one 1B, type 1B or type 2 external fixator repair or a ring, and dog will be completely fine. So sure.
Okay. And what about pain management?
Dr. Gaikwar, so the pain management, I'll just give you in general the pain management for all the fracture repair. All of these fracture repairs will get an epidural for the hind limbs, of course, and for the front, if it's radius, we do rum block, which is radial ulnar musculocutaneous, and median nerve block. So that's how I start with that. So the epidural is already in, and then dog will be fine for 6 to 8 hours. And I'm done with the surgery. It takes about like 40 minutes or so. After that, we normally put them on multimodal analgesia, so an anti-inflammatory like Rimadyl or carprofen or meloxicam. I'm not sure back home what is the most common anti-inflammatory being used. When I was there, I heard about diclofenac. I don't know if it's used in dogs or cats or not. So anti-inflammatory, and then I use an opioid like codeine, tramadol. You can use any of those. And then I also use some kind of like calming medication like trazodone or acepromazine, so that they're not moving around a lot and then causing more inflammation, which will cause more pain. For the first 3 days, the inflammatory, if you read about the physiology of inflammatory period, first 3 days, the inflammation kind of rises and then plateaus and then comes down. You need to read the biology and physiology of these, like, the basic ones. So if you know that, then you can always talk to the pet parent doing some ice packing or icing. So I recommend that for 3 days or 3 to 4 days, because after that, there's no need of doing ice packing because the inflammation has gone down. So ice packing, multimodal analgesias are important for pain management. There are other techniques that in a compound fracture, sometimes I'll put them on fentanyl drip or the CRI of the fentanyl. Or in the hospital, they are normally here for 1 day. They are getting injections of methadone, hydrocodone, even buprenorphine or fentanyl to take care of that. And then, of course, Rimadyl, carprofen, or other anti-inflammatories. So I hope that answers your question, Dr. Gaikwar.
Yeah. There's one more, like, do you use bupivacaine at surgical site?
I do. So the method, what I use here is a long release bupivacaine in fat ossicles, and that's the trade name for that is Nocita, Nocita. So again, it's Nocita, Nocita. So I would inject that. Normally I do that for like elective surgeries like TPLOs, those kind of surgeries, but mostly it's epidural in conjunction with the other drugs. And of course, yes, you can use bupivacaine in these and long lasting. So totally very, very good question. And I'm happy that we are talking about some pain management.
Yeah, because as you suggested, many of them in India also, they are using meloxicam, carprofen with tramadol. So even fentanyl patches are also useful, as suggested by Dr. Santosh Gaikwar.
Yeah, fentanyl patches are useful also, but with opioid crisis in this country right here, I normally don't use it. You put fentanyl patches on them, and it's possible that the owner may remove it and put it on herself or himself. So I don't use that.
Okay. So there's one more question, like after healing, the fracture pin can be removed, or it has to be kept?
The plate?
Yeah.
Okay. Well, let's talk about that again. Most of the times, I don't. There's no need to. Although there's a small paragraph in the discharge instructions which says that the plate or the implant, the surgical implant, will stay in dog's leg forever unless there is an SSI, which is surgical site infection, which can happen 5 years from now, which is infection, and then only I remove it. I normally do not remove it. I myself have had surgery done on my wrist and my plate is still in. They have not removed it. So I'm not sure why we keep talking about removal of this. It's another anesthesia, another surgery, and there's a chance of removing the plate and refracturing caused through the screw hole. So be aware of not, unless there's something which the plate is bothering, then only remove it. In a normal situation, answer is flat out no.
Okay. Do we need physio as post-operative in case of tibial fractures?
All fractures need physiotherapy. But here's the deal though, the dogs are, they tend to put weight 2 to 3 days post-surgery, toe touching. And by the time I see them for suture removal in 2 weeks, they're actually putting almost like 50 to 80% of the weight. And yes, we need physiotherapy. So it's gentle movement of the joints up and down. I mean, joints proximal and distal to the repair is needed. And I tell these guys to make sure the dog is being walked and not carried. So let's talk about a little bit of physiology here, why physiotherapy works. So you want bone to heal. If you read the biomechanics of bone healing, there's this nice law by a surgeon, Wolff's law, which says that if bone is under pressure, it will heal well. Well, how can you create a pressure? Well, put some weight on the bone. Well, how do you do that? Well, let the dog walk a little bit for pee and poop and come back, don't carry. And that's a good, nice physiotherapy also. So yeah, you should definitely encourage them to do physiotherapy, which is movement of joint up and down of the fracture, and have the dog be walked gently with, of course, the leash.
Okay. One more question, like neutralization plate. Could you throw some light on it?
So one steel plates, let's say it's a LCDCP, or we don't use DCP anymore. That's like very like 1960s or so. Now we use like LCP, which is locking compression plate, or LCDCP with grooves inside. So that plate can be used in any fashion. It could be used as a compression plate. It could be used as a neutralization plate. It could be used as a bridging or buttress plate. Depends how you place it, what is the fracture configuration or so. So if let's say it's a simple fracture, oblique fracture, the case number 1, and I use wire, and wire has reduced everything, and if I plate if I put a plate on top of that bone, that will be known as a neutralization plate. Now, if it was a transverse fracture, if you guys have attended my first lecture, which was radius unlocked, where the goal was to compress the fracture and then put a plate, that's a compression fracture. But I'm using the same kind of plate. We can have a long lecture on biomechanics of bone fracture repair later, but for now, that's it.
Yeah. Dr. Anjali is asking, like, will the presence of plate after surgery restrict growth of bone in young puppies in any way in long term?
Yeah, very good question, Anjali. So let's talk about that. Now, you need to be aware that in young puppy, where you're putting the plate. So in case 3, I put the plate below the growth plate. Okay, so looking at the bone, if you're not hampering the growth plate and the screws are not going through the growth plate, or you're missing it, then it will not cause any problems. But if the screws are going through the plate, up and down or something like that, you just stapled the growth plate, and yes, it will cause problems. So be aware of that. And how to repair young dogs fracture repair, especially the green stick, is another topic to discuss, and I teach them, or it's a very advanced course, and the method is known as elastic osteosynthesis, meaning that you're putting a plate which is moving a little bit. And again, you need a little bit of movement and pressure for bone to heal quickly. And we can talk a lot about that. One of the experts here, one of the AOVET faculty at Michigan State University, Dr. Loic Desjardins, has pioneered in repairing those, how we can quickly achieve that, especially the young patients. So the answer to your question, Anjali, is that it will not affect if you have missed the plates, growth plates.
Okay. So Dr. Lennett is asking, is pentose and polysulfate sodium as an active ingredient useful as a post-surgical lavage? Appears that this is being used in USA. Do you have experience on the same?
I don't. Maybe Shiba can answer that this quickly. But here is this: I do not use at the fracture site. Remember, this drug is, I use that, a different form of the drug. This drug is mainly for the joint health. We're not dealing with joint. We're looking at the bone, the long bone fracture. If if we can have a lecture on joint surgeries, maybe we can talk a little bit more about that. But no, the answer is I don't use to lavage these things because the pentosan sulfate is important for chondrocytes. There's no chondrocyte in the dead center of the bone. It's either in the joint up or joint below. So again, liberal physiology.
Okay, now there are people who have said that good suggestion about implant removal. Thank you. And many of the doctors have said thanks to you for the good presentation, good information shared to all of them. And I think there are no more questions now. So with this, thank you, Dr. Jha. I'm thankful to you for this very good, wonderful session, a very knowledgeable one where in tibia fractures, we get more of information. If anybody wants to have chat or questions, you can please join Dr. Jha's Instagram link, which is already here shared. And the same will be shared by us too. So thank you so much, Dr. Jha. Mr. Vikas.
Yeah. Okay.
Thank you, Dr. Jha.
Yeah. Thank you so much, Dr. Jha, for such a wonderful presentation. And I was very happy to see a lot of involvement from the people end, right? And that kind of interaction would be always motivate us to keep conducting such kind of webinars in coming future. Yeah. So thank you so much to Dr. Jha for such a wonderful presentation. And really very thankful to all the delegates who shown their certainly overwhelming response to be involved in the lecture and asking so many questions, which is certainly a good insight for all of us people. Yeah, thank you. Thank you so much, Dr. Jha. And now we have another wonderful judge lecturer is Dr. Shiba. So just a little bit brief about Dr. Shiba. Before proceeding with Dr. Shiba, just a special announcement for all of you. Vetna has just introduced a few months back a redeem loyalty program called VetCoin. So VetCoin is something, it's a loyalty program. So with a certain reciprocation, what we decided, so whosoever will be the part of this webinar, as a just token of appreciation, just to keep aware what exactly the VetCoin, we would be sharing the 100 VetCoin with each one of you, which can be used in any time of any transaction with the help with the Vetina by buying any product or any services. So just a small introduction of VetCoin for all of you people. And now take to the Dr. Shiba. So just a brief introduction about Dr. Shiba. Dr. Shiba is a veterinarian and marketing manager for Swati Spentos, and she is registered and certified veterinarian. She has completed her BVSc from Nagpur Veterinary College and done his post-graduation MBSc from the Mumbai Veterinary College. She has been a part of this Swati since last 2018, and she's working with this formulation of pentose polysulfate for the canine formulation. They are already there in equine formulation. So with the so much involvement of Dr. Shiba, they come out with a canine formulation of pentose and polysulfate. And with her expertise on this subject, she will be entitled us on this novel product today. So we'll welcome to Dr. Shiba to put some light on this product and just share the knowledge of the share with all of people here. So over to you, Dr. Shiba.
Yeah, thank you, Vikas, so much. I'll just share my screen. Yes, is it visible? Okay.
Yes, it's visible. Yeah, please.
Hello, everyone. So after a wonderful lecture by Dr. Jha, so I would like to continue by presenting a product to you all. So this is Pentos. It's an injectable for canines, and it's primarily used for osteoarthritis. I would like to begin by introducing the molecule and understanding how we developed it and how the whole procedure took place. So Swati Spentos is a human and veterinary pharmaceutical company established over 50 years ago. So we have key experience in manufacturing and marketing pharmaceutical products in the niche category. We are one of the largest commercial manufacturers of pentosan polysulfate sodium API globally, apart from the originator, with complete control and backward integration on the manufacturing of the API and the finished formulation. So the API is developed from a source called as beechwood and then integrated into the formulation. We are currently conducting research with prestigious universities across the world for pentosan in new indications. We are currently working with 10 global scientists who are working on different indications of this molecule, including process chemistry, analytical chemistry, and clinical studies, which gives us a clinical and scientific backup. So the few important proofs which we rely on is our global lead, that we are global leaders and authorities on the subject are the proof that our API site is a US FDA site. So we have complete knowledge on the subject of characterization, our patients benefiting in India and several other countries. We have also been exporting this drug for the last 6 to 7 years now. So Pentos, as I said earlier, is an injectable used for osteoarthritis, and the key ingredient is pentosan polysulfate sodium. It has been used since the late 1980s and is one of the most favored products by veterinarians across the world for the treatment of osteoarthritis and other musculoskeletal disorders in horses as well as dogs. Initially, we began by introducing this product for horses, and we were successfully distributing this product in India and other countries like UAE, Singapore, Hong Kong, and Macau. So as we saw excellent results from all these countries, we thought of getting the product even for canines. So we have been active in the equine segment for over 8 years now, holding great experience in this product through our partners worldwide. And now we want to share that expertise with you on the canine front. So moving ahead, let us go and understand how does this molecule work and what is it used for. So often pet parents are questioned, and they have a question in their mind that why is their dog not jumping with joy and limping with pain? So often pet parents have multiple questions in their mind as to what is the problem, what is the pain behind it, and they're unable to understand why suddenly the joints of their pet is swollen and painful. It could be so painful to touch, and the dog could be whimpering all the time. So every time the dog tries to perform any activity, there is a soft whimper of pain exhaled, and that could get your pet parent really agonized and could be really confusing as to what is causing such kind of behavior in their pet. So there is always a question, is there something that we can do to heal this pain off and treat the problem off? So what could be one of the leading problems which is causing the swelling of joints and pain? So that gets us to osteoarthritis. Osteoarthritis is one of the leading joint disorders seen in dogs. It has been estimated that around 30 to 50% of dogs will be affected by osteoarthritis at some point of their life. Depending on the breed or age, it could vary. So this condition causes a long-term degeneration of the joint and involves many tissues, including your cartilage, bone of the joints, capsule, and your synovial fluid. So what are the key symptoms do we observe in osteoarthritis? That is stiffness, lameness, and painful joints. Coming to the causes, what are the major causes which cause osteoarthritis in dogs? The first leading cause is age. As the dog progresses in age and gets into the geriatric phase of life, it does face a lot of wear and tear of the joints and the bone. This causes painful joints and swelling of the joints, which in turn causes osteoarthritis. The other cause could be larger breeds. That's like your German Shepherds, Labradors, Golden Retrievers, Great Danes. Because of their structure and larger framework, there is a lot of load put on their joints because of the weight of the animal. That causes constant wear and tear. The other point is obesity. As the dog is heavier, that causes more load and friction of your joints. Next is the repetitive stress of athletic activity. So dogs which constantly have activities of running, show dogs, they have constant pressure put on their joints by the constant activity of jumping and other activities. The next one is mechanical injury. So that is a direct force or trauma to your joint, which can cause your joint to be injured and then cause the whole catabolic reaction in your joint, which causes osteoarthritis in turn. Next is your improper nutrition. So if your joint doesn't receive the proper and adequate nutrition it requires to maintain a healthy joint, there would be a constant wear and tear, and your joint won't be able to maintain the catabolic and anabolic activities. The last but not the least is your genetic makeup. So the genetic makeup, if the dog previous parents also face the same problems of osteoarthritis, they would in turn also face it. What are the current therapies which are available for osteoarthritis? The go-to therapy currently is your NSAIDs. So since they are used constantly for pain management and inflammation, and since that is one of the primary symptoms which is observed in osteoarthritis, your meloxicam and carprofen is used. The next is your supplementations like your hyaluronic acid, your chondroitin, and your glucosamine. These help in increasing your HA content and your glucosamine content in your synovial joint and helps to maintain a healthy joint structure. The other treatment which is used now currently is your CBD oils and other supplementations of CBD. So these are also used as pain management supplementation, and it's in recent studies it's showing a lot of pain improvement for the joints. The other physical therapies which are available is your physiotherapy and hydrotherapy. These are physical activities which are used to increase the activity between the joints and help in physical therapy between. The last but not the least is your acupuncture. For this, you need high expertise in the subject to perform it. So coming to what is Pentos 100? Pentos is made of an active ingredient called as pentosan polysulfate sodium. Pentosan is a semi-synthetic polysulfated polysaccharide. This molecule was developed by Swati Pentos over a period of 10 years with the expertise of international scientists and other vets. This is derived from a plant source called as beechwood, and it has mild heparin-like properties. PPS is mostly used for the oral formulation to treat interstitial cystitis in humans and osteoarthritis in animals. This is the only drug which is classified under the disease-modifying osteoarthritic drug. So coming to how does this drug work in the body and what is the mechanism of action? As we know, our synovial joint is made up of chondrocytes, and that's the point of where the whole reaction begins. When your chondrocytes are, it causes mechanical force to your chondrocytes, it causes loss of your proteoglycans and your collagen. So loss of proteoglycans is the central pathological factor of your osteoarthritis. Once there is loss of your proteoglycan, there is loss of elasticity, and that causes wear and tear of your joints. So your catabolic activity of your joint increases, whereas your anabolic activity decreases. This causes apoptosis of your chondrocytes, and that's why that it in turn causes an immune reaction to your joint. This makes all your leukocytes and your other immune responses to come to the joint and cause a reaction of repair. This increases the inflammation and your blood clots. That's why the whole process keeps on going in a circle and in a repetitive stage unless there is a stop to all these factors. So how does pentosan work? So pentosan initially inhibits the proteolytic enzymes and decreases the loss of your proteoglycans, which is the key point of your osteoarthritis. Then it inhibits all your destructive enzymes like your interleukin 1, interleukin 6, and TNF-alpha. Once this process stops, due to its nature of having heparin-like activity, it breaks down your blood clots and increases the blood flow to your joint. This in turn increases the nutrition to your joint and tries to maintain the healthy nutrient and the healthy joint environment for your joint. Pentosan also works on increasing your HA concentrate. HA helps in increasing the viscosity and the concentration of your synovial fluid. This increases the lubrication between your joints and decreases the friction between your joints, which causes less chondrocyte damage. In turn, it initiates chondrocyte regeneration. So coming to this diagram, you can see the exact activity of how there is the different activities which take place in an osteoarthritic joint. Due to the mechanical force, your cartilage breakdown takes place, and that causes the activation of your leukocytes, and in turn causes procoagulative activities. This causes vascular occlusion and bone necrosis. This also causes abnormal synovites and inflamed synovium. This decreases your hyaluronic acid and reduces your viscosity and lubrication. So as you see, pentosan works on the asterisk points of these activities. So pentosan works on stopping these activities and renewing your joint and giving it a healthy environment to sustain. Coming to what is pentosan exactly? So Pentos canine injection is a sterile pale yellow color solution, which is an aid for the treatment of non-infectious inflammatory joint diseases in dogs. Pentosan polysulfate sodium is 100 mg per ml. The dosage for this is, in canines, it is 3 mg per kg body weight, given subcutaneously every 5 to 7 days for a period of 4 weeks. In case of severity of case, this can be repeated again after a period of 1 month rest period, and not more than 3 courses should be repeated in the year. That is 12 injections in the year. So in milder cases of OA, 1 course every 12 months, moderate cases of OA, 1 course every 6 months, whereas chronic and severe cases will be 1 course every 4 months, or 1 course and give a 1 month rest period and then repeat the course. So these are the primary indications it is used for: osteoarthritic traumatic joint diseases, osteochondrosis dissecans, degenerative cartilaginous joint disease, musculoskeletal disorder, and your periarticular inflammations. So what are the benefits of Pentos? It has anti-inflammatory action, fibrinolytic activity, counterproductive agent, reverse effects of osteoarthritis, inhibition of your destructive enzymes, and stimulation of your hyaluronic acid. So these are the contradictions of this drug. Pentosan, being a plant-based origin, it doesn't have that many of side effects in the body, but occurs in patients who have hypersensitivity to this drug. This may show gastric sensitivity like emesis, diarrhea, or anorexia. We need to take precautions in the following cases. Do not use this treatment for septic arthritis. So in case the animal has an infectious joint, we would recommend first let the animal be treated with an antimicrobial treatment, and then once the infection is healed, we could resume to your Pentos. Do not use it in dogs with advanced liver or kidney impairment. Do not use this in dogs with blood disorder, coagulation disorders, or bleeding or malignancy. This is because the molecule has slight heparin-like properties, so this could cause excess bleeding in such dogs. Pentosan polysulfate also has anticoagulant effect. So do not use this in perioperative stages, that is 1 week prior to your surgery and 1 week after surgery. Do not use it in skeletally immature dogs. So the dogs whose bone plates aren't matured enough, please we don't recommend using in those dogs. Once the dog reaches a matured age, that's when you could begin the course. Do not administer pregnant and lactating bitches. So this is a comparison between the 3 current therapies available in the market. One is Pentos, the other is NSAIDs, and the next is supplementations like HA, chondroitin sulfate, and glucosamine. As you can see, Pentos helps in the inhibition of proteolytic enzymes, stops the breakdown of the cartilage, has anticoagulant effects on the blood clots, inhibits loss of proteoglycans, inhibits destructive enzymes, increases your HA concentration and molecular weight. So those are the components where your NSAIDs don't work, because they primarily work only on the inflammation and pain management. Whereas your supplementation do help in your HA, increasing your HA concentration. The next is targeting pain receptors, suppressing the immune response, increasing your production of proteoglycans, and increasing blood flow to the joint, and prevent bone necrosis and sclerosis. So in these also it is debatable, because your NSAID works in some areas and it doesn't work in the others, whereas your supplements also work in some areas and it doesn't work in the rest. At the end, the primary focus is it reverses the effects of osteoarthritis, which is only seen in Pentos as a molecule. So what are the key USPs of this drug? It is completely safe with no reported side effects. It has anti-inflammatory action, which helps reducing joint inflammation and pain. Counterproductive action and inhibition of proteoglycan, which helps in turn further reduction of further destruction of your joint and initiates regeneration of the damaged tissue. Stimulation of your hyaluronic acid, increasing the formation of synovial fluid, which helps in the lubrication of the joint. Technically, this product shows a long-term effect as compared to other treatments currently available. So our key focus has always been on relieving pain, restoring function, and renewing hope. So we want to break the pain cycle in canines. While pain is inevitable, suffering is not. So if you want to get a hold of this drug, please contact Bettina for this, and they would help you out with it. Thank you.
Thank you. Thank you so much, Dr. Shiva, for such a wonderful presentation. And thank you so much to all the delegates to listening so patiently to Dr. Shiva. But we have already prepared a beautiful video. I think that most of the audio and video presentation makes the things more easily understandable. So just have a look of that video which you prepared. It's a wonderful video, just a 2 minutes video we'll share with you. And you can have a look on that too also.
Osteoarthritis is a leading joint degenerative disorder seen in dogs, which show unexplained pains in their limbs and swelling of joints. You may often find them whimpering in pain every time they try to jump, run, or walk. Why does this happen? This condition causes long-term degeneration of joints, including many tissues like cartilage, bones of the joint capsule, and synovial fluid. This results in stiffness, lameness, and pain. Pentors is being introduced as an easy solution and treatment to osteoarthritis for your dogs by Bettina. This module is classified under DMOAD, disease-modifying osteoarthritis drug. It constitutes of an active ingredient called pentosan polysulfate sodium that is derived from a plant source called beechwood, most commonly used as an injectable drug to treat osteoarthritis in animals. The Pentors works by acting at multiple junctions in the interconnected pathway of pathological changes occurring in the articular cartilage, subchondral bone, joint synovial lining, and the synovial fluid in an osteoarthritic joint. Degeneration takes place when mechanical factors act on healthy cartilage and subchondral bone, causing the release of proteolytic enzymes that break down the healthy tissues as well as cause the synovium to get inflamed, which leads to an abnormal synoviocyte metabolism, decreased hyaluronan size, and reduced viscosity and lubrication of the joint, finally leading to the breakdown of the cartilage and damaging of the bone. The damaged bone further causes synovitis, thus repeating the same process again and again until the complete loss of bone or joint function. What Pentors does is that it acts at a number of points simultaneously, breaking the chain and creating favorable conditions for bone regeneration activities. It inhibits the proteolytic enzymes and decreases the loss of proteoglycans as well as inhibits destructive enzymes like interleukin-1, interleukin-6 and TNF-alpha. Due to exhibiting partial heparin-like qualities, it also breaks down blood clots to increase blood flow to the joint, which cures bone necrosis and sclerosis and also reduces inflammation and pain, and finally increases the hyaluronic acid concentration in synovial fluid, leading to increased viscosity and lubrication in the joints, thus initiating chondrocyte regeneration of the damaged cartilage and bone. This Pentors works on many types of conditions, including osteoarthritis and traumatic joint diseases, osteochondrosis dissecans, degenerative cartilaginous joint diseases, musculoskeletal disorders, and periarticular inflammation. Plus, it has been proven to have zero side effects due to its origin being plant-based, thus being a completely safe drug for the dog. Choose Pentors. Relieve pain, restore function, renew hope. For inquiry, call or write to us on 912067 445858, 91750 Email ID customerservice@vetina.com. Visit us at www.vetina.com.
So this is all from our side. Thank you. Thank you so much to all the delegates. We really thanks from the heart, bottom of the heart. Thank you so much to be the part of such a wonderful webinar. And maybe within a day or two, you will get a message for Vetcoin also. So please keep remember that it's just a loyalty program to just keep you aware what exactly the Vetcoin scheme is. Yeah. If anything would be needed more, you can anytime approach us, and we would be very delighted to have you people on board. And we'll be continue such kind of webinars in coming future also, with the help of Dr. Shanti, Dr. Shiva, and many more people also. Yeah. So thank you so much to all of you people to joining with us. Thanks a lot. Yeah. Thank you so much, Dr. Jha, for such a wonderful presentation, and thank you so much to be part with us. Thank you so much, Dr. Shiva, to be the
Mr.
part with us for such a wonderful presentation. Yeah.
There are a few questions. I
Okay.
think Shiba would like to answer them.
Yeah. Please.
Yeah.
Yeah, there was a question: is pentose and polysulfate sodium as an active ingredient useful as a post-surgical lavage? Appears that this is being used in USA. Do you have experience on the same? The first part you can definitely answer.
Yeah, that's what I said. It can be used 1 week prior and 1 week post it, not during, because of its heparin activity. So that would be the suggestion. So that the molecule is not present in the body during the time of surgery.
Yeah. And the second question is, can pentose be administered in epileptic geriatric dogs who are on phenobarbital or levetiracetam?
So it can be administered. We have not seen any reaction as such. It is only we advise that it should not be given in combination with any NSAIDs. So once the dog is on pentose, so any kind of NSAIDs should be withdrawn from administration at that point. So the dog should be just on it. So that is, otherwise for other drugs it is completely safe. There are no interactions.
Is it a one solution for all bone disorders? It's a question from Dr. Samar.
Yeah, it is a solution for joint disorders as long as it's not a septic joint. So any joint disorder which is not infected, it works perfectly for it.
Okay. Dr. Khadim has asked Dr. Jha, can you share your presentation with him? He has given his email ID. Just let him know.
Yeah, but Dr. Khadim, we have already recorded entire webinar. And if you want, we can share even the first webinar, second webinar with you also. Even I have noted down your mail ID with me. We can share with both the recorded webinar with you. Not with you, but most of the people, those who have registered this webinar, we can share with you. Yeah, maybe by Monday or Tuesday, we can share with you. Yes.
It's available on YouTube. As you can see, the live recording is going on. So it's available on YouTube also. And there are many people who are saying thank you to Vetina and thank you to Dr. Jha as well. Thank you, Dr. Shiba. So there are no more questions, I suppose.
Yeah, so from the Vetina side, certainly we would be very thankful to all of you, especially for all the delegates and all the lecturers. So thank you so much to be the part of such wonderful webinar. Thanks a lot, everyone. Thank you so much. Yeah.
Thank you. Yeah.
Thank you, Dr. Jha. Thank you, Dr. Shiba.
Thank you so much,
everyone. Thank you so much.
Have a nice evening and have a nice weekend.
Yeah.
Thank you.
Bye.
Bye.